basically, that's a very, very important question. As much as we think this is straightforward, it could be complex sometimes. So the most important thing is obviously making sure the patient has hypertension, and all of us are aware of the false positives or false negatives while we're taking blood pressure. Extremely important to have the blood pressure cuff exactly matching the patient's arm circumference. Obviously, having a smaller cuff leads to higher blood pressure numbers than needed. Number two is obviously having the patient sit and rest for 5 minutes and then take the blood pressure. If someone's taking blood pressure medications, usually 1 to 2 hours after the medicines are taken. And obviously, the situations where people have white coat hypertension is challenging. This is where we count a lot on home blood pressure readings, and if the patient does not do that, we highly encourage that. And there's the opposite problem of masked hypertension, where patient has a normal blood pressure in the office but is significantly elevated at home. That is also something to be aware of. In terms of other factors that make the blood pressure reading false is subclavian disease, meaning blockages in the artery providing blood flow to the arm. If one has obviously a stenosis or an occlusion getting collateralized, obviously important to check both blood pressure, both arms, and sometimes both arms are occluded in vascular paths. So that's also something to take into account. And finally, very calcified brachial arteries. When patients, mostly with renal disease, have very stiff arteries, usually the blood pressure reading with a sphygmomanometry is slightly more than the actual invasive pressure in the aorta. So obviously, a diuretic is an extremely important component of antihypertensive management in patients with hypertension, because most of the time there is this genetic tendency to retain salt, or even if there's no genetic tendency, the other blood pressure medications would not be working optimally unless the volume status of the patient is normalized. So it's one of the basic steps that most providers start with. We usually start with thiazide diuretic therapy, and we know for sure that chlorothalidone is not only more effective than hydrochlorothiazide, but also longer acting. So we focus on that. The challenge is to break that 25 milligram tablet in half, and there's not much benefit beyond 12.5 milligrams from a blood pressure reduction standpoint. There's more hypokalemia with the 25 milligram dose. Now, mineralocorticoid receptor antagonists are the core of the management of patients with resistant hypertension. The most recent guidelines focus on the importance of hyperaldosteronism as a main reason for resistant hypertension, and in patients without significant renal insufficiency with creatinines less than 2, we usually, if obviously the clinical presentation fits hyperaldosteronism, we definitely recommend that spironolactone at 25 milligrams, eplerenone, which doesn't have the gynecomastia side effect in men, is usually recommended at higher doses. The equivalence is almost double. So almost 25 milligrams of spironolactone is equivalent to 50 milligrams of eplerenone, and we can keep up titrating. Rarely we had to go above 100, but it has been done before. And finally, in renal insufficiency patients, a lot of people are scared to increase the diuretic, even in patients who have clinical hypervolemia. So they come into the office, they have jugular venous distension, they're really congested, they have edema, they have pleural effusions, and usually physicians or providers are very nervous starting diuretic. In this case, we would have to use loop diuretics unconventionally to decrease, to improve the volume status of the patient, and ultimately maybe combine it with thiazide diuretic. But it's very important, the role of loop diuretics in renal insufficiency patients. Yeah, this is a very important point. We usually think about secondary hypertension whenever the onset of hypertension is relatively early. So, someone less than 30 years old who's starting to have hypertension, especially if the hypertension is accelerated, meaning it's progressing at a very fast rate. A month ago, it was 130/80. Now it's in the 160s. That is usually alarming. If it's associated with spontaneous tachycardia, this raises the uh, etiologies of endocrine etiologies like pheochromocytoma or hyperthyroidism. Also, when the blood pressure is not responding to 3+ medications, including a diuretic, that's also something that allows us to think, maybe this doesn't fit essential hypertension. We have to look for causes. And of course, if the symptom presentation is associated with symptoms that are suggestive of another cause, so someone's sweating profusely, having headaches, that suggests pheochromocytoma. If someone is extremely young and has a difference in blood pressure in both arms, aortic coarctation comes up. If someone has symptoms of hyperthyroidism like diarrhea, insomnia, and mood changes. So the clinical presentation is extremely important to take into account when we evaluate, especially patients for the first time. And of course, if physical examination findings are suggestive, like renal artery stenosis with a bruit in the abdomen, the importance of thorough physical examination. What diagnoses? We're looking at, obviously, the basically adrenal gland related conditions. So Cushing syndrome with increased cortisone secretion, pheochromocytoma, increased secretion of metanephrines, obviously hyperaldosteronism related to benign adrenal hyperplasia or other conditions affecting the adrenal gland. Of course, renal artery stenosis, especially in the young patient population. If they're women, we think about fibromuscular dysplasia, not the atherosclerotic etiology. Aortic coarctation is something that's very pertinent in young adults who have discrepancy in blood pressure between the arms and the legs. And other most important conditions currently in the Western civilization is obesity-related hypertension, which obstructive sleep apnea is a main one. Not that fixing the sleep apnea would fix the blood pressure, but it helps. Other conditions include excessive alcohol intake. That is something that is frequently ignored. And of course, sedentary lifestyle and the obesity by itself can lead to inflammatory changes in vasoconstriction. So for a chronic kidney disease, obviously one should really count on their physical examination skills. As we mentioned, hypervolemia, often these patients are not clearing fluids as much as they can, especially if their creatinine is above 2.5. So the tendency to use loop diuretics in addition to other antihypertensive medications unconventionally, we don't usually think of loop diuretics as being antihypertensive, but you need to really help the volume status at the same time as treating the hypertension. Secondly, this is challenging from a mineralocorticoid receptor antagonist. So we know that spironolactone and eplerenone are relatively contraindicated when the creatinine rises more than 2, sometimes more than 1.5. Those patients also have the tendency to become hyperkalemic when we put them on small doses of these medicines. So caution is really highly indicated, even if patients have signs and symptoms of hyperaldosteronism. So they need to be monitored closely with blood work in 5 to 7 days after initiation of therapy. The other major positive change lately that is not specifically dedicated to hypertension management, but for patients with chronic renal insufficiency, are the non-steroidal mineralocorticoid antagonists like finerenone. Finerenone is a phenomenal medication. These kinds of medications as patients, especially in the setting of diabetes and congestive heart failure. This is a medication we can use in patients with advanced renal insufficiency. It actually decreases the progression of chronic kidney disease. And ultimately, future trials, in my opinion, will hopefully prove that it has almost the same effect on hypertension management as patients without renal insufficiency. So these are kind of the issues I would think of in renal patients. And of course, one would think about renal artery stenosis as a bilateral renal artery stenosis as a possible cause of hypertension, or if someone has a solitary kidney, the idea of checking the vasculature of the renal artery of the kidneys is very important as an etiology. Now, in patients with diabetes, obviously extremely important to focus on ACE inhibitors and ARBs, angiotensin receptor blockers. This is especially true in patients with diabetic nephropathy who have albumin in their urine and have evidence of target organ damage from a diabetes standpoint. Very important to be very practical, to put yourself in the position of the patient. Obviously, a 3 times a day medication is almost a big no-no, unless you're really running out of options and you're on 5 medications, you can't use anything else. So focusing on a once a day or at most twice a day medication is one of the most important aspects. Secondly, even though we really love blood pressure control, if patients are pretty sensitive, to kind of start in stages and see them more often. And if your schedule does not allow for seeing the patient every week, maybe have a nurse visit, have alternative visit, or have the patient call your office with blood pressure numbers and then gradually increase. That improves adherence. Thirdly, if someone has social issues that prevent them from taking a diuretic like other patients, and they are really embarrassed to go to the bathroom every 30 minutes, and they either have a job that prevents them from doing that, probe into why they don't like this medication, not just say that the patient is non-compliant. There are real world reasons why patients are not non-compliant. And of course, besides the frequency, it's the price. Obviously, make sure now we're kind of blessed that most of the medications are generic, but in special cases where generic medications are not working, obviously probe into the insurance coverage issue, the cost of the medication. This is a lifelong treatment most of the time. And finally, one could be taking their medications, but drinking a lot of alcohol, especially in the middle of the night. And that makes them more resistant. If they have sleep apnea, that's not being addressed. However, number of medications we go up on, if they're suffocating every night with frequent hypoxia, that's going to raise their blood pressure during the day and their sympathetic drive. So that's one of those things that we address when we see lack of response.